So we have, welcome to this innovative course. But before that, we have a keynote address from Dr. Nitin Verma. He's going to talk about the geopolitics of eye care and how ophthalmologists are making a difference in that geopolitics, even in the new era, called the Trump era, right?
Thank you. There we are. We have the slides on. Right, thank you. Thank you. Look, this is more of a story than anything else, but just to give you a background, I am from Australia, and we have the Royal Australian New Zealand College of Ophthalmologists, which is an institution that's involved with training, institution that's involved with standards and so on. So it's not an association, it's actually a training institution. But the problems in that part of the world, especially where I work, is usually slightly different from the rest of Asia, where for us macular degeneration, glaucoma, and diabetes are our major issues. That shows you the distribution of ophthalmologists in the region. They're all concentrated around the best parts of the place to live in, which is the coast. But, it's all very nice, but we do have problems in Australia. And we have an indigenous population which has got a very high prevalence of blindness and vision impairment, which is much more than the rest of the population. And every year we get a report from the government saying what they're doing. And every year it shows that it's not possible to close the gap between the indigenous population and the rest of Australia. And so, we are bombarded by reports all the time, and really not much work is happening. So I think this gap that we are talking of between the indigenous and non-indigenous population is one of our biggest problems. Of course, the disease patterns are changing, and just after COVID, I went to meet the health minister, and I said, look, I'm not very happy about the direction the government is taking, and whether you would have the funds and whether you would have the direction post-COVID to be able to handle all this. And so he said, look, why don't you work with the government and tell us what to do? So that was the first point of contact between the profession and the government, and we coined this Vision 2030 and beyond, because I think it's a fundamental mistake to say we'll finish everything by 2030. That never happens. So this was launched in 2022, and really it's got 6 pillars: workforce training, service delivery, closing the gap, preventive health, sustainability, and global eye health. And I'm going to just touch on one or two of these. Why are we paused? So this whole thing started in, that ophthalmologists doing things many years ago with Fred Hollows. And one of the projects that's going on in Western New South Wales, where Sydney is the capital, it's only for 125,000 people, but they are spread out in an area that's the size of France. So their services are delivered by aircraft, by road, and so on. In the northwest of the country, where all the mining is, the distances are even more, and there's a different model being used there, where vans such as this travel and actually see patients, treat them on site, and then they use aircraft also and use telehealth. So that shows that there's been increased accessibility for Aboriginal patients once all these measures have been put in. So here are some pictures, and this is a complete, ophthalmologists, optometrists, nurses, health workers, and all together. And of course, they've been doing a lot of research in terms of getting the database on all machines for Aboriginal patients too. I think they've been working with Google. The relationship between India and Australia also is evident in many remote parts of Australia, where we've got doctors who can work under slightly more difficult conditions, are manning ophthalmology services, such as in the center of Australia in Alice Springs Hospital. So we have a similar program in 2024, and we have brought the whole eye care sector together. Now remember that in Australia, 85% of health service, eye health service, is delivered by private practitioners, which is quite unique. And so it's also a big challenge trying to put everybody together. So we have to work with optometry, we have to work with orthoptics, we have to work with the general physicians and so on. And so we've been running workshops to come up with consensus areas, not where we disagree, but where we agree. So when we present to government, we tell government, look, this is the direction we move forward. The government wants to listen to one voice. They don't want 5 people coming and telling them 5 different things. So we've had a very positive outcome from these workshops, and the government now calls the ophthalmologists and say, okay, what do we do in this way? So that is the win that we've had for the profession and therefore for the patients. We, of course, are involved with media advocacy and sending messages to the public about where things are going on. Some examples of positive steps have been increase in number of training positions, and also we are demanding from the government that they have KPIs. When they give money, they should say, well, there are KPIs, otherwise you don't get any more money after this. We want to create an atlas of healthcare delivery standards so there's uniformity in the country and so on and so on. So look, it's a big process, but this is the important part of ophthalmologists engaging with government, dealing with politicians, utilizing things like the elections as key points to push the agenda for eye care forward. So we collaborate with a lot of organizations in the country, and we have a similar program in New Zealand. Remember, we are Royal Australia and New Zealand College, and they have a different system, but their problems are basically quite the same. Coming on to the 6th pillar of this, which is our global health platform, we concentrate on the Western Pacific Rim as well as the South Pacific. When you tell somebody about the South Pacific, you think of a thatched hut and people dancing and you're having a nice sit on the beach, but actually the problem with the Pacific is not so Pacific, right? Economically, the Pacific hasn't recovered from COVID. And in the Pacific, we've got a small population of over 12.5 million people spread out over a very large area. If you leave Australia and New Zealand out of it, it's 12.5 million people. But what's common in all these people is there's a very high rate of visual impairment and blindness, and really diabetes is coming in, the demographics are changing in, and I think the future doesn't look very bright. It doesn't matter which country you look at. There's very limited capacity within the Pacific Island countries. For example, they said this country of 120,000 or 220,000 has got one ophthalmologist. One ophthalmologist can do nothing. So we need to really see what we're going to do. My own journey in the Pacific started in 1994 in Papua New Guinea, and you can see us operating on boats, but the second part of the journey started in Timor-Leste 25 years ago when they got independence, and over this time we've been able to set up their whole system and handed it over to the government in 2023. So over a 15-year period, the RAB showed that the prevalence of visual impairment and blindness reduced from 7.7% to 2.8%. And I think that things are still improving. So why was this program successful? That's because we utilized some very unusual, not standard things. For example, we sent people for training to India and New Zealand, India and Nepal from there. We didn't call them to Australia because I believe that they have better training here than the standard thing of bringing them to Australia. They can do much more, and of course they create good links. We had education and educationists coming from all parts of the world, a truly global classroom. We sent them for very short-term fellowships, go and learn specific things rather than spend 2 years doing all that, and worked on the complete eye care workforce. So, but I think the greatest achievement was that we engaged with politicians right from the beginning, and they really made sure that any small hurdles were going over, so were fixed. And I think that's the important thing when you embark on programs like this, that you engage with the government and the politicians. So now the rest of the Pacific has come to us and say, we also want programs like that. So we have now focused on the rest of the Pacific, which are 14 other countries. But all this has been possible not because of the strength of RANSCO alone, but also our links with organizations in India and Nepal. We have MOUs with All India Institute, we have MOUs with AIOS, and we also wrote to the Indian Prime Minister and the Australian Prime Minister saying we are working together in this space to tackle the issues of blindness, especially due to diabetes. The All India Ophthalmic Society has last year started work in Samoa. Here are some pictures from there, and also in Tonga. You could recognize Samar Basak, he's your president, who's just finished. And we also have a WhatsApp group that works as a telemedicine base for the whole of the Pacific. So anybody in the Pacific sends in a de-identified problem, the response is generally available within 24 hours. We invite them, the Pacific Islanders, to our annual meetings. And we're also working with Dr. Sahu's organization, International Society for Manual Small Incision Cataract Surgery, by improving cataract surgical outcomes in the Pacific. We've held workshops in Fiji. This is a recent workshop which is very well regarded, and they want some more. We're also looking at the effects of climate change, which are very, very close to the heart of the Pacific Islanders, and looking at carbon footprinting, not only for cataract surgery, but also for intravitreal injections. So we're learning a lot from India. We're learning a lot from what's going on here into what would be best practice, not only for the Pacific, but also for the rest of the Asia Pacific. And the college has put out sustainable practice guidelines for not only cataract surgery, but also for injections. We have a program where we get refurbished equipment, get it certified by the company, and actually send it across to hospitals within the Pacific, and this is looked after by companies such as Zeiss and Alcon and so on, so that the equipment get a second lease of life. Here's a colleague of mine who's got a 56-foot boat, and he goes from island to island transporting equipment and just creating that little link between these things. So lastly, this effort was able to speak to the health ministers of the Pacific, bring eye care on the agenda. They formed a resolution which was adopted by the Commonwealth Heads of Government meeting in October last year in Samoa. Here are some photographs of that. So really we've been able to bring eye care above the horizon so that I think it's got a good future. All this is important, as you said, in Trump's era because there is so much uncertainty in the world. COVID was one. The current situation is the second, and I think it's no longer business as usual. We just need to make sure that as ophthalmologists, we continue to be clinicians, scholars, researchers, but also advocates for the patient, which requires connection with governments and understanding of what's going on in the world. So I'd like to end by saying that on the first we had an AIOS RANSCO function. The New Zealand High Commissioner was the chief guest, and he had one message, and he said when societies get together, when doctors get together, it makes it much easier for governments to do their business because they've got the professionals in front. Thank you.
Thank you, Nitin. I think the most important part you touched at the end was the sustainability part, which is very important, at least for us to do this kind of a good work, especially in outreach and underserved. Unless we sustain in our regular work, that will be very difficult to do. And I was just seeing a news that the people who are kind of governing the sterility now are all squashed. Their jobs went off yesterday. It's a big news there. The team which found that the tear substitutes were contaminated, that team is gone. So people are worried about a lot of things, but it's so important in keeping in touch with politicians is also quite important. I mean, you touched upon all that. Thank you again for giving the keynote address. Welcome to the course. So this is going to be very interesting because this is something I've never seen before happening, but we have a decent attendance now. but I hope it will fill up in a short time. But basically what we are trying to see is how we can teach better for the next generation, because the next generation is quick in everything. No, they want reels, they want shorts. No, like for example, I was telling my residents, for the first time ASCRS has introduced shorts in film festival, 2-minute video, and they have something called high impact pearl in the main session, which is 1.5 minutes you have to to a better way for the Gen Z, I would call it, who were born with the computers, who were born with internet. But I think somewhere now we'll have to kind of balance between the old way and the new way. So this is a course which will try to touch on some of these aspects. I have a terrific panel starting from my good friend Deepak. You may all know him. I've been closely following him. He's a real influencer on YouTube. I mean, some of his videos have tons of views. Whenever I go and see the about to see how many views does he have. Collectively, I mean, that shows the kind of the time and effort he has put to make some of those content. And what I at least learned from is it's just not the content, it's the clarity of the content and how contrasting it is, and several other things looking at his videos. But more than that, I like his philosophical talks. And one such talk was when I had him talk to my resident some time back. I said, you have to talk about that. Are surgeons really born great?
Tells us the fact that certain and I'll just fear which most of us have, which I had. Like, I would, because I dedicate this presentation, these thoughts, all which I've got to my teachers and to the next generation teachers as well, because this is how we transmit knowledge, and this is how the entire world ultimately gets benefited out of it. So the common concept, discussion which we used to have as a child at my home is like, we used to discuss about somebody's blessed with a great hand. And I'm sure you must have encountered, आपका हाथ गुण बहुत अच्छा है साहब, उनका हाथ गुण अच्छा है. This is a common thing which is there. So from my younger days, this was really which fascinated me. Like, are somebody truly born with this? Are they truly gifted? And when you are doing residency, you will feel that some of your peers are doing better than you, and you get such an inferiority complex there itself. And you're convinced yourself that you are not good enough, and that's the end of your career. You'll be thinking whether I've chosen the right specialty as well. I would have got these doubts when I was doing my residency as well. So, is it a myth or a fact? When you Google out and you found out that, I found that this picture is from Google. It shows that, I presume this is the God which is directing the, eye surgeon there. So it just justifies that ophthalmic surgery is really very, something to be proud of, where we require divine intervention to get it right. So this is what it is. Now, it is really mystical and fascinating, and especially for the budding young surgeons, you are told that either you have it or you don't have it. Hath kaisa hai iska? That's all they ask, that's what it is. That, and it's such a demotivating thing for the younger surgeons, and you're convinced that you're not made for it, cut it for it, okay? So let me just take you through it. I believe that surgery is done with the mind and not the heart, okay? So you are getting, the hand is getting undue recognition. So actually the great surgeon has trained his mind to such an extent that he or she can anticipate, plan, analyze, and then implement this. And that's the reason why the results are better in particular group of surgeons compared to other. So it is not just the hand, okay? So I believe that if there's one message which I want all of you to take is, it is done with the mind and not with the hand. Dexterity of the hand is critical, okay? It's important, especially as an eye surgeon, but it is not the most critical thing. It's not the most critical thing. What you have to have is intelligence, knowledge, and creativity. And of course, as surgeons, any surgeon, courage forms an important part. And because we are going to fall, we are going to fail, and however, what is the ability for us to get up again, that's what defines us. So these are more important attributes to have rather than, just best with the thing. And second thing, another important thing, if you have got the best rank in your multiple choice question exams and you got the best college, and somebody doesn't have a good grade and he has gotten a very mediocre college, that also does not differentiate from you becoming a good surgeon or a bad surgeon, believe me. So you can have a surgeon who has qualified from the top college, he might not be good enough, but a surgeon who is from mediocre college, he can still be good. So there are not, a single aspect doesn't differentiate you from being a good or a bad surgeon. Again, a point to note. So good surgical judgment is probably the most critical thing which differentiates an excellent surgeon from an average surgeon. I'm just going to, and this is something which can be got by experience. But the whole exercise of my presentation is you don't have to spend 20 years to get this judgment. As mentors, we can train our young surgeons to develop this judgment at an early thing. So how do you train this? Again, you have to train the mind. That's the one thing. So I believe the surgeons are made, okay? Surgeons are born great. I think it's a myth, but let me counteract like this. I am involved in training quite a lot of young surgeons and interact with a lot of them, and after having a reasonable experience of in this field, I would like to say that if you classify, you take 100 surgeons, 3% of them are extraordinary. They're blessed. There's no doubt about it. Okay, the God has been very kind to them. They are extremely intelligent and they've got extremely good eyesight, which is very critical for eye surgery. Maybe the depth perception is superb, and they've got superb stabilized hands. That also is there. This 3% are blessed. Maybe like Sachin Tendulkar. No, you can never have a Sachin Tendulkar who can play for a country at 16 years. He was truly blessed. And on the contrary, there is also a 3% of them who are poor, who can't learn surgery. That also is a fact. I have come across this group as well. The reason is they are not interested to improve upon. And the majority of us which fall in this 94%, that is the average category, and this is where I'm really interested in. And if we can put in effort, we can squeeze majority of them into the top 10% group, and that is what is required. The candidate should have the right attitude and they should get the right guidance from their mentors. And this is a typical learning curve which we discuss about all the time when you're learning surgery. To begin with, you're clueless of what you're doing and you're naively confident. I think you'll learn the surgery until you have a major fall like this, and this becomes discouraging and it is realistic. This is where you feel realism, and now you're really doubting yourself whether I'm fit enough to become a surgeon. So let us watch. This is a typical learning curve which we see, Over a period of time, you become from a novice to an expert surgeon over a period of time. But what improves over a period of time is ultimately the quality of decisions which you take. From poor, it becomes optimal or good. That is what experience does to you. So this is the journey to the mastery, and this is the typical levels of learning, what you can say. So actually you're unconscious about your incompetence, first of all, when you begin with. When you become conscious about your incompetence, then actually the learning happens here. And this is a very common question asked to me, okay? How long does it take for me to become an expert? Okay, in terms of time, in terms of cases. So, well, the answer is simple, okay? You just look in the mirror, you get the answer. You can't blame the system, you can't blame the mentor, you can't blame anybody. Look in the mirror, the answer lies there. Some surgeons can pick up surgery in 100 cases, 500 cases. Some cannot, even after doing 5,000 cases. And it takes, somebody might pick up in 1 year, somebody can pick up in 10 years. So it depends upon the self itself. That's it. You can't blame anybody else. So, but the matter of the fact is, eventually you can upgrade. The only issue is how much time. So it is differentiated. everybody cannot master that particular step or that particular surgery in 100 cases. Somebody can take 200, somebody can take 500, somebody can just take 50. So I've encountered all these categories. So can we accelerate the learning curve? That is what a goal of a mentor should be. So I have divided this into three surgical skills, 3 steps, okay? The learning the motor skills, dexterity, that's what we improve dexterity. Second would be there are certain secrets which have to be shared by the mentors. There's no other way because the person has to learn, it will take a long time. Second would be the decision making aspect. This again has to be taught by the mentor so that you're preparing the candidate well enough for doing this. So just watch this video. This is one of the young surgeon who's done maybe the first, second or third case, and just look at the hand movements which you're seeing. Okay, so this is something which is a motor skill. Look at this case again, look at the way the hands are trembling and shaking. This is a motor problem. This is something to improve upon. And there are multiple ways to do it. And I have had people who have access to the machine learning. What is it called, Venkatesh? The thing? Simulator. But I feel, now how do you improve your motor skills? I still feel that, that may not be the best way to do it. And I feel suturing, learning suturing, I think a 10-0 nylon suturing, that would probably be the best way to improve your surgical skills. Of late, majority of us have stopped suturing now. And that is the reason why you're just trying to do phaco and rexes, that's all it is, like playing a video game. I want you all to go back to suturing, 10-0 nylon suturing, and just chart your progress through it. How much time are you taking to complete 10 sutures? How much of them are of good quality? And this is, you grade according to yourself. That is how you are going to chart your progress. So that is one of the important tips I'd like to say. If you want to improve dexterity, I think start suturing. And maybe 1 hour suturing per day, if you're your target, you will definitely improve over a period of weeks or months. And next would be decision making, which has to be taught. Unfortunately, common sense is not so common. That's the reason why this is important. Now, this is a surgeon who has done about 1,000 surgeries. And look at the thing now. This is a fairly complicated cases. Even for an experienced surgeon, you would think twice what it is happening. Now look, it's a brown cataract. Rexis is done, rexis is not done, and the nucleus is moving along with the bag. Can you see this? And the surgeon is so confident about himself. He's trying to do the job here by sculpting here. Okay, just look at it here now. The nucleus is too hard and he's not using the right power, and he has certain belief in himself that he can crack this. And this unwavering belief among himself, that's what he's doing, and he doesn't stop until watches what happens now. So sometimes this overconfidence is such a thing just goes down. And now he's successful, okay? Now he's very successful in pushing it down. So what is the problem here? The problem is self-assessment is wrong. Your own self-assessment is wrong. You believe that you're skilled enough to do that, and this is a case which definitely doesn't fall into the category. So your awareness itself is an issue here. So 1 more minute for me? Yeah, sure. So practice, how to improve your hands, practice with suturing. Second would be observe your mentors, how they're operating. What is the way they're trying to get the support of the hand and the wrist. I think the best way would be to find a way to support your hands. If your hands are shaky, try to support it using patient's cheek or forehead or something. Actually, our mentors used to tell us that, it's your hand, bloody, you should support it. Why are you recording anything else support? That also you have. But if you're finding it really difficult, try to find some support there. So decision making in crisis, every complication you should have a game plan to begin with. Okay, we don't want an Abhimanyu-like syndrome. So you should have in every possible situation, like nucleus drop, endophthalmitis, you should have a descendant membrane death, everything you're going to encounter in your career. If you're not so lucky to have encountered until now, you are going to encounter. Have a game plan, not about just how you're going to manage. So I would recommend to divide this complication management into 2 aspects. Intraoperative strategies, which is clinical based, Second would dealing with the patient. Because whenever this happens, you're more worried about what am I going to tell the patient rather than actually dealing with the things here to do the right thing. And that is going to mess up your thing. So, you have to by heart these strategies. Okay, nucleus is dropped, no problem. I'm not the first person in the world to drop it. So these are the things which I know to by heart. I don't want to fish for the nucleus. I want to minimize minimus. I want to protect the endothelium so that my VR surgeon can pick it up easily. I don't want to mess it up firmly. And then you close it. And then next would be what I'm going to tell the patient. What phrases am I going to actually use to the patient? This is what you need to learn and by heart. So the cataract could not be removed, unfortunately. It was not accessible. It is behind and it cannot be done in my setting. Don't worry. I'm going to arrange for the management of it. This reassurance is going to help you a lot. So this is what I want all the mentors to train our younger colleagues for this. Prepare them for the battle. Most of the when they come out, they're so, that they're not at all battle ready, neither technically nor in the mind. So that's the reason why it is an urge for both mentors as well as the. So I think my time is up here. So I'd like to conclude by, so nowadays, you can be your best teacher here. The only thing I would like to see is record each one of your surgeries and analyze honestly and develop a true sense of, self-awareness and be a self-critique. That is what you are going to be, it's going to benefit you in the long run. So believe me, you can be your best teacher, but be honest with yourself. Thank you so much for your patient hearing, and thank you, Venkatesh, for the opportunity.
Deepak, we're going to get back with a few slides now once we have time at the end. So I want you to be here. Okay, you can go and come back. If you finish there, you can come back. But anyway, if you have any quick questions, we can ask Deepak because he wants to leave, but we'll try to get him back. But it's so important what the message is giving. Even if you have all the new innovative things, I think the old school in this thought is very, very important, where you have to be calm and composed in whatever we do, in the training and also when we have a problem during the training. So we'll go to the next talk by another good friend, Dr. Prasanna. I'm sure many of you know him. So he's been showing these gadgets to me since he was a resident in Mahatma Gandhi Medical College. And I said, it's just not you seeing it or somebody. Can the whole younger generation benefit from it? And that's where his whole thought process changed, and now he's trying to bring in a lot of teaching activities through virtual reality and augmented reality, and I wanted him to share his experience on that.
Thank
If you have access to wet lab facility, you have animal eyes, you can practice there. But it may not be possible to get that. Practice on your gloves, okay? You have a gloves, find a way to put it across, stabilize, make a cut and then suture. That's the best way.
Thank you, Venkatesh sir. If not for the Pondicherry days, I would not been into innovations inspired by you, sir. Thank you for this wonderful opportunity. So VR and AR and especially what's the way forward. So traditional ophthalmic teaching was all about Halstead's, can I have a laser pointer please? Yeah, laser pointer please. Traditional ophthalmic surgeries were based on Halstead's methodology. It's intense and repetitive, where you have to, you are told that just keep repeating and you'll be learning it soon. So performing surgeries, it was a predetermined number of procedures that you had to, keep pushing yourself. That's what it was told. And there is an inconsistent skill acquisition and risk of patient exposure to inexperienced surgeons were also there. So then came the practice of animal eyes, where it won't suit human tissue, no real tissue challenges, lack of fluidics, and there were some major limitations in them as well. So that's when I started venturing into virtual reality and augmented reality, and COVID also really helped me get this up and rolling. So can augmented reality enhance the precision in microscopic procedures? So this was another literature which paved a light called the CAT AR, the novel AR based stereoscopic, and which uses infrared optical system with 2 cameras, and this has been well published, and this was one of the papers that struck to my mind. As you can see, it was a stereoscopic augmented reality system with dexterous instrument, and it really gave you a real world immersive experience of how things are. So this was one of the modules that I was also closely following, which had a good amount of accuracy and the sensitivity and specificity that a good simulator needs to have, especially a circular tracing and an anti-segment navigation. So this was my own concept called the IMG AR, where I tried to make a science fiction concept to a science-based reality one, where I started in a very simple way using the phone's LiDAR technology. So in the smartphone, when we take a selfie, we tend to have a hat or have a bunny ears. These were some of the things that our children used to play with. So what I used the similar technology called the LiDAR technology, and in this piece of paper, if you are going to throw your phone and switch on the application, you will get the holograms in the phone. So that was how it started for me. So we created an application where it detects this piece of paper and you would get the hologram. So that was how it started as a baby step, because for me the challenge was, can we make the phone itself into a table like thing where you can mount the phone and then get the eye as a hologram, where then you play along with it with whatever instrumentation, or even to deviate a bit, the three-dimensional undissectable structures that we ophthalmologists don't get to do or don't get to see actually, even in dissection classes, the circle of Willis, the cavernous sinus. We always tend to imagine structures cognitively, and that's how we actually learned majority of ophthalmology, if you actually see. And then I started pushing into more practical scenarios like hydro dissection versus a hydro delineation. Can we really show where we need to place the cannula? Because we all have mentors who draw on a piece of paper and tell us that this is the plane that you have done a dissection wrongly, and maybe this is where you might need to do, be it rexes or be it whatever. So this is the rexes that we have almost cracked it at our center. So these are some of the very exciting times, because this is another novel technique for posterior polar cataract. But the idea here, what I'm trying to say is, if a three-dimensional evaluation or a three-dimensional representation of a surgical procedure, be it a hydro dissection or a hydro delineation that you tend to do, which you always mentors, when you go back, your mentor draws on a piece of paper after a complicated OT, and you also try to imagine things. In the OT field, you are on your own. You don't even get to know whether you are in the right plane or not, and you end up with making a complication, and different people will be having a different complication profile. So this is a first holographic eye model with true confocal images. You can see the fundus, and we used photoreal mirroring for the angles, and try to keep it as realistic as possible, and we evaluated it and published it widely in European journal as well as the Indian journal as well. So the model that I made, you can see on the left hand side, just a smartphone. You don't need those fancy simulative headsets or the gadgets, and you can see this paper. That was how I started. I'll be taking you through in the next 6 minutes as to where I am also now. So on day one, you can actually orient to the angle into the retina, undergraduates or postgraduates or a fellow or a retinal surgeon who is aspiring to be. You get to see, so on the right hand side is the mobile camera view, left hand side is what you see on a camera, and when you move your hands towards the paper, you enter into the fundus, or when you come out and when you move towards the angle. So you got this complete cognitive three-dimensional orientation just on a smartphone, an offline app, and cost effective. When I launched it, I did not even charge the app, and it's still free of cost. So these were the models that really started to make, because ophthalmology was needing more of neuro-ophthalmic touch as well, to deviate a bit here. So I brought in this subtractive learning. It works for other anterior segment surgeries too, where as I was moving towards, I realized that textbooks were giving more of what the author wanted you to see rather than what you want to see. So I added a button here that can we, give the author that he decides that I don't want this, can you remove this? I don't want the brain, or I don't want the brainstem. So he is choosing what structures he wants to remove, and that way he decides what frame of choice he wants to see, rather than the author telling us what he wants us to see, rather than we giving the user the empowerment to actually go ahead. So just a bit deviation here, but I'll come back to the anterior segment and cataract surgery. The eyeball is here again. So these models were all made by myself. I had to do a lot of things I didn't like, especially reading Cunningham's, because I had to get the three-dimensional bending correctly, because there was not much of guidance when I referred books. There was not much of 3D oriented guidance. So I remember 1.5 2 years, I was just past anatomy. If not, I would have failed also in first year. My dad was also very worried about my anatomy results more than anything. So you can see again the angles here, the angle recess, everything we were able to make exactly how a neophyte would want to see. This is again a brain model of the sulci and gyri that I made, on the right hand side. Yes. And just a bit of, and this was one simulator in smartphone which I am very fond of even today, which is a simple direct ophthalmoscope. So nowadays when my postgraduates come to me, I don't speak to them. I just open this and I give the phone in the hand and I tell them to move into the pupillary area like this. So they move into the pupillary area and they go into the fundus like this. So doesn't it make it very interesting? So they know how they need to do a direct ophthalmoscopy, front, back, they go front and back, and I immediately pass the phone from the right hand to the left hand so that they get their left hand orientation. Otherwise, most of the surgeons they tend to hold the 90D or 20D only in the right hand for both eyes. And it is very disturbing for the patients. I always feel right eye you need to use your left, and for left eye you need to use your right. So ambidextrity training also was very important facet, and this was the whole high, and this is my own model, and we are still working on it to evolve it better. And this is another anterior segment simulator which we recently cracked, and another patent which I recently filed. So this is like the Johnny Quest. The millennials will know what is Johnny Quest. Once you wear it, see how your hands are looking. Real time, this is how your hands will look. It look like as if a binary code is there, and you take a mix injector and you go into the angle, not once but twice but multiple n number of times. You can go and place the stent, which the company doesn't give you more than 1 or 2 times, and you may sometimes even not get a model also. So once you place it in the right plane, you can go back to your surgery and you can master the art of microscopic surgeries. These are surgeries which are very demanding, especially on a scale of minimally invasive phenomenon. These are things to simulate real world experience, and the principles are, these are the 4, my dear friends: pre-reading assessment, instructor-led training, supervised practice, and simulator supported learning. And for me it was always this movie was the one which got me going, because I really thought, can I do this? And when I told to my friends or my father, he just told me, you go to the OT and operate 100 cases a day. That's what we do as ophthalmologists. So then, but I had my own way, and this is my recent simulator module that I am working on. It's a trainee interference VR learning loop, where I am trying to work on the difference between a vertical chop versus a horizontal chop. So can I work on a simulator, which this is a vertical chop that I am currently working on, and this is an horizontal chop, and my idea is to bring it economical. So all the innovations that I have made, I have not charged it, or rather it's actually free of cost. And I also feel, for completion for the next minute, IC is there, Phacovision is there. These are not mine, but I just thought I should just show certain videos for the benefit of my fellow colleagues and novices in the group. So these are some of the simulators you can go, and these are widely available on YouTube, and I'm not going to go into the depth of it. Phacovision is one, Microvis Touch is one, Alcon Fidelis is one. I recently I was able to get my hands on, and where we had a conference on it, only on this simulative training. And you won't believe, for 2 days we had 54 registrations, and 20 minutes we kept one slot, and there was so much of crowd. People did not want to listen to lectures, whereas they were very actively willing to participate in these kind of modules, in these kind of learnings, because that is what I really felt when we did one in Trichy last month under YOSI. And I think this is a very promising, I'm just finishing on time. So Help Me See is also there, and I'm not going into the other simulators. So the studies are very promising. Literature shows from 2011 to 2023, the meta-analysis all comes to one conclusion: it enhances learning, improves safety, skills are improving, especially for CCC, continuous curvilinear capsulorhexis, shortens the operating time, increases the confidence, and transforms the whole way we understood the whole spectrum of learning. So these are my references, but most of the work that I showed were actually mine. I wanted to keep it most of my work, and I just touched upon the names of the work which is available in the market. So I am Dr. Prasanna Venkatesh Ramesh. You can catch me here on Instagram, mail, or on WhatsApp as well. Thank you, Venkatesh sir. I would have not been the same in innovations if not for you and if not for my Pondicherry journey. Thank you, sir.
So I think when you were showing now how you remove the brain, now now I see when I use the new AIs, now it's literally removing my brain off. When I start writing it's happening. Now it's prompting the differential diagnosis. It's saying you have to do this. I don't know where the brain is going to go. No, but that's the way now the new generation wants to learn, and of course you know how TSTC and other things now attract a lot of people, because this can make your learning curve much smoother. Because the better the learning curve, the more the confidence. Even back at home, now people say number, but where is the number coming from? Number comes from confidence. Confidence is equal to the number. That's what I say. The more you're confident, automatically your numbers will come. But wherever you practice, depending on where you practice, I think it'll make a big difference. But it's not just learning and doing, but also thinking out of the box. No, not doing the conventional way, but also thinking out of the box. So I have another good friend, Nivian, who always keeps thinking out of the box. I just wanted him to share how he thought out of the box and how he was able to make that into a product, so that the youngsters here would also think like that in the future. No, unless you do that, you may not see a lot of changes which we see happening now. So we need to work on that, and I think definitely you need support from a lot of people, maybe from engineers, industry, but he's going to share his journey.
Thank you, sir. So respected teachers, senior ophthalmologists, my dear friends. So I'm Dr. Nivian. I'm just going to talk to you about how you can bring your idea to clinical practice. And there's no better way to share it with my own journey about the CMT Flex IOL. So as you all know, I think you all do your thesis and you all come up with different innovations and ideas. But then there should be a long-term goal, or you should have a long-term plan for whatever you have. It's not that after 3 years it gets over, or 1 year it gets over. So always try to look for a longer, can you just cut out the volume? So as far as all of you know about aphakia management, more than 30 years we have been having different methods like the claw lenses, anterior fixated, then posterior fixated, then sutured lenses, then the glued IOL, Yamane, so all these were there. So me being an anterior and a posterior segment surgeon, I was always interested in PCR and secondary IOLs. So what fascinated me was the idea, why not have a IOL specifically designed for this kind of an aphakic treatment, rather than using IOLs and modifying the techniques. So that is the thought that came to my mind that led to this. So always start drawing, scribbling, but don't forget where you started. So this is how the journey started of the CMT Flex, like I want something different. So the specialized T-shaped, we had different designs. So that's how the idea begins. But then idea alone is not enough. So what I've learned is, like, if you want to travel alone, you can run faster. But then if you want to go longer, you need a team. So these are very important things. So you have to choose. So first of all, for my case, it was a lens. So I also need a manufacturer. So it's not that I have to do everything on my own. So that's where you start looking for a reliable partner. But it might vary for your product or what you have invented. So we partnered with Apasami, because at that time they were also innovators in encouraging youngsters to bring out with whatever innovations they had. So I explained the idea to them. But then there are hurdles. The company thinks only about the financial aspects, and you think about getting something invented. So there's always a clash. So the initial phase will be very difficult for you to convince them that but unless you do the trial and have the research done, you cannot prove anything. So there's a gray phase always, and that you have to all overcome very strongly, and you will have to pitch it to them. So I think that is why, like some programs like Shark Tank, I think Venkatesh here, sir, because without Venkatesh sir, even I wouldn't be standing here, because of his programs, that what you see on TV, that you come and pitch your idea, and then it doesn't stop there. You have to take it to the next stage. But we had a clear vision. So I wanted to treat these aphakic patients better than what they ever done before. So you should also be clear about what you wanted. And this was the first prototype design that we had in 2018. So then I said, so once you have the design, now all the hurdles that start coming. So first of all, then I learned from Subin sir about patency, because he was the one that time had done the BX ring, and he was very kind enough to say like how important getting a patent filed for whatever product you do, because all of you might have, because you never know. See, we are a vast population, and this helped because at the same time, during my journey of patent filing, after a year, I found out there's another lens like a Caravelle lens, which is very common in Italy, and he also had started at the same time. And then 1 year later, we found out that you all must be knowing about the scleral tuck lens that's also there. So that's also another type. So getting your patent done for your design and applying for the patent before starting your work, or telling it to the outside. See, in 2018, I could have presented about it, but then that is not the right method what I've seen. And many things have stopped at that time. So make sure you have your patents done, all your regulatory approvals. So then only I learned that every lens, that whatever IOL we use, we has a CE certification, a mark, a license, and all this. So you learn about all those things. So licensing is very important, because without licensing, they cannot sell the product. Then for you to do the study, like how nowadays ethics has become a very important part for your thing, so you need the ethical clearance before starting off with the trials. So these things also, you should have somebody who can guide you in that, and make sure all this is done before you start your thing and before you talk it to the others. It is not about coming and showing what you have done, but you should first see whether what you believed in is actually working and it is benefiting. So it took us 2 years to get the certificate approved. So it taught me that I also had to go to court. I had to face their questions. So it was not about doctors or anything. It was just about the design. So it's a totally new dimension that I had sitting there, and non-doctors asking me questions about the design and what is aphakia and how it is useful. And then successfully after 3 years, we launched it in Salem in 2020. That time Dr. Mohan Rajan was the president, so and Satyen sir was there. So we had a very successful launch in TNOA, and then subsequently the 2 months following in All India Delhi. So we launched it in Delhi. So, and that is when the lens was supposed to be released. The day when we landed back in Chennai that weekend, that Monday, I think the lockdown was announced, and that was the starting of the COVID. So what again I'm trying to tell you is there can be various obstacles. The day I launched, and even before I could sell the first lens, and this is what happened. So you always have two choices again. So again, you can be sad and keep cribbing about what happened. How I believe is you take every negative criticism and try to turn it into positivity. It is very easy said and done, but I have grown up like that. So when people say I can't do that, I try to do it. When they say you are not doing that, I still try to do it. It is not to prove them a point, it is to prove yourself, and that gives you that you go out of the comfort zone to do something extra. So then it actually gave me time to rethink, reevaluate about the design, everything. But that time I came up with some new instruments also. I said, now we have the lens, but we might have some specialized instruments also designed. So why not have it as a kit? So that's when we introduced the CMT Flex kit, and then we modified the design to make it less bulkier what you see from the previous design. Then I started the study, and then people started using it. So as I said, it is not only you, unless other people, like this is, we are the field of ophthalmology giving vision, so we all have the common goal. So unless people use it, and their feedbacks are very, very important. There again, I'd like to quote only Venkatesh sir. From the day I introduced it, he must have forgotten, but till today, every time I present everywhere, he comes up and tells me what has to be done and what should not be done. He told me on day one when I let it, do you have any publication? I said, no sir, I don't have. Do you have any study about the sclera and how this sits over the sclera? No sir. Have you thought of doing OCTs? No sir. So every time he said something, but I went back. I was not a student like that. I was always the last bencher in my class, even till today. So, but everything he told me, I took it up and went back and worked on it. Because that is what has added up to me, for me to think outside the box and what else I have to do. And then I came out with the publications, the local journals, the national journals, the peer-reviewed journals, PubMed index journals. But there again, I worked with my team. It was not only me. You saw Prasanna presenting here. So we worked together. Dr. Madana Gopal also. We all worked together. So I did a couple of multi-center studies. So now to show you about the clinical aspect also. So it is basically for aphakic treatment. So this is a case of an aphakia which was planned for a secondary CMT Flex IOL. So we usually mark 0, 180 degree and make two 2 by 2.5 flaps. and then you make a sclerostomy 1.5 millimeters away from the limbus. So these are specially designed CM Pranav forceps. This is 1.5 millimeters away from the limbus. The other advantage of the lenses, it can be done through a clear corneal incision. So initially we were doing here because we were all used to clear corneal incision here. Then I thought, why not? Because it is easier to grasp these lenses rather than going here at a 90-degree angle. So this we call as the head-on position. So initially I was holding the neck of the part. So what happens is that time there's a bulkier portion that comes out. This is a head-on position. What happens is when you're pulling it out, you see the 2T bends inside. So that's a lesser diameter of the lens that comes out. So that makes it smoother for the lens to come out through the sclerostomy. And again, being a single piece, I've heard people that there is breakage. So what I say is, wait till you release it from the cartridge. So don't pull it out as soon as you hold the T. You release the remaining of the lens from the cartridge and then pull it out. So then it smoothly comes out, pops out and stays there. It's because of the specialized T-shaped haptics that you don't need to tuck the lens, you don't need to suture the lens, or you don't need to glue the lens. It just sits in the position. But again, the 0-180 degree is very, very important because that's where the lens is going to sit. For the other side, the handshake technique and exchanging to the other hand, being the material it is really tissue forgiving, less traumatic inside the eye, and just wait for it. So once this is done, it is almost over. So you don't have to do anything else. You get nice round pupils. We also have an angulation of the lens. So all these things, developments came because the angulation is given between the optic and the haptic, so that there is no rubbing of the iris, no pigment dispersions. As I said, these were the studies of UBM. This is the OCT through the sclera, because sir said in 5 years people are going to ask you how are the reactions of this material. So after all this journey, then it has been like people forget what you have done 7 years back, but today, so I was happy, but at last the recognition came when it actually people started using it all across India. So we had, this was last year, but now I think it's cost more than 5,000 implants because it's catching up faster than I do. We have many surgeons. The main thing is I like to thank all the doctors who have tried it and been very happy with it and been using it. So this particular photo was last year's in ASCRS, where I would say, like, when you do something, don't look for some results, but then it will eventually land you up somewhere if you keep consistently doing your work. So these are the session where they had all the inventors of secondary IOLs. So you might see me hiding somewhere. So this is Canberra, Yamane here, then Canberra here, C. Shung Fake, Amar Agarwal, George Baiko, and then so we had an exclusive session on all the different types of thing. So this was totally unexpected. It was giving me over the moon, but that was after 7 years of hard work. So, but the journey did not end there. My learning still continued. So I would always say learning never stops. It's like, I didn't see any seniority or juniority because Venkatesh sir was my teacher from Arvind Eye Care System and Prasanna was my junior. So people have started modifying the technique. And just one small thing is you should always have inspirations. So in my journey, so the entire name CMT Flex, I don't know, even though many of them don't know, it is after my mom. Her name is Shalini and my dad's name is Madhivanan. So that's why the CM came from. I always thank my teachers from Shankanitra and Arvind where I've learnt everything. Yeah, my wife for being flexible and tolerable for all the idiotic things that I've done in this period. And none of this would be possible without good friends. So if you want to achieve something, make sure you have a team with you that understands you and criticizes you, not keeps telling you you're the best, you're the best. It's not that way. My mentors here, Sahu sir is another example. He was the one who introduced me into MSICS, and that gave a rebirth and relearning about SICS. See, it is what I'm trying to say, learning never stops. I used to be the fastest in Aravind, I can boast, but then now what I'm learning from SIC is something more different, that even for multifocals through 2 millimeters incisions. So that's what I'm saying. You need a team to guide you and you need your friends to take you along. But take the criticism in a very positive way. So only then you can learn. That's what Deepak sir also said. You try to learn from your own mistakes and be the better version of yourself. But have a dream big and keep working hard. So all these things put together is what the journey is. So I'm happy here and thanks once again to Venkatesh sir, Sahu sir for all their inputs and supports. Night 11 o'clock he'll call me and say, anyway, is it ready? And I said, no sir, sorry sir. No. So you should get some positive energy and the passion those people have. They say we are youngsters, we are the next generation and all that, but I feel we are a little lazier than them. We have a lot of learning that we have to do from them when it comes to discipline and working hard on something that we want. We are always focused on the results, that we want to be there, we want to be the best. how is that person driving this car, how is that surgeon making so much money. I think all this comes secondary. Give that investment of 10 years. Thank you.
Brilliant, Vivian. I didn't know the CM T-Flex story. I mean, it was so nice. Now you kept your parents and your mentors and your place where you practice, all that in the lens. So it's nice to have that story. But that's a story I think each one of you have to kind of embrace now, because you will have to think out of the box. No, if not, it's very, very difficult. So I'm going to share with you in the next 15 minutes, like how we have done some out of the box practices. Like whatever Deepak was talking to you, we have kind of systematized that, because we believe that systems are going to help us in the long run, especially in institutes. And I'm going to share how we have kind of systematized some of that learning curve practices, or when you're moving from one stage to the other stage. So this is where I think he left. Are surgeons born or made? When he was talking about that, I was browsing, and there are several articles on this. And the message is very clear. The literature suggests that surgical expertise is reached through practice. Surgical experts are made and not born. So that 3% can be like born surgeons. It can be Aik Ahmed, my good friend Gabar Shariat, who does the sutureless scleral fixation. But that is just a small number. But there is a big number where usually they are made by deeper understanding of the nature of expert performance and its development will ensure that our surgical education training programs are of the highest possible quality.
Excellent.
Can you escape and check?
Slides.
Can we switch there? Sita? Can you switch there? The mouse I'm not able to see. It's going there. It's okay. Let it be like this. Okay. So this was the steps which okay. So this was the steps which I think Deepak was beautifully showing. How do you go from the unconscious incompetence to the next stage, the conscious incompetence? And that's where a lot of things happens in your learning. The stages of learning is very important for us to understand. So when somebody is unconsciously incompetent, what we do is you read all those things. You read all the basic books, and then you watch a lot of videos. A lot of resources are there. I don't want to get into those resources, but we also run a beautiful channel called AuroTube, where we have the best manual small incision series. And for phaco, you have a lot of online resources, including Deepak's and many others in the form of iTube and all that. But again, the next important thing is whatever you're doing, I think you have to understand the basics of it, the basics of the machine, the handpiece, the foot pedal, all these things are very important. And then how that works, the parameters of it, like power, vacuum, aspiration rate. Sometimes you have to spend the time to really understand all this. So before it was like more the sheer volume, but now with all the simulation and wet lab practice, you don't need that numbers to learn and master a technique. So that's where we also use the Help Me See simulator, and we have also studied to see how it really helps. You can see, you get a real feel. For example, this is a simulator for SICS, but you can also do for phaco. You can have a feel like how you are doing a scleral tunnel, like how you see there. You can go at a certain depth and then feel the depth. If you're too deep, it would say you're too deep. If you're shallow, it will say, if you're too superficial, it say there is chance for you to buttonhole. So sometimes you need some of these simulators. Now these simulators are available in Mumbai, in Madurai, and several other places, but you will have to go enroll and make sure you do this practice so that you have a good learning curve before you touch the human eye. The second thing which we developed several years back, so this was what I developed maybe when I was a resident, of putting a human nucleus into a goat's eye. There is nothing like this, I'll tell you. You can put the human nucleus, the one which you have harvested from small incision, into goat's eye, and you can practice this brilliantly. So this is not done on one side, and you close the incision by suturing, and from the other side you make a phaco incision, and you can really feel how firm the nucleus is, how deep I should go, when the red glow is seen, when do I stop, when do I chop, or even if you are from 4 quadrant to stop and chop or phaco chop, you can do all that. See that beautiful rotation which you can do. You can practice all that just on a goat's eye with a human nucleus which you have harvested from small incision. So even new techniques, I asked my team to get back to the wet lab. If let's say that you are externalizing a haptic, go to the wet lab, practice that, and then get back. Let's say that you're putting an iris soak, go to the wet lab, practice. It's not that the wet lab is only in the beginning, but even in the longer period, when you're moving from one technique to the other technique, this really helps. So what we do back at home is like one-on-one training. Each resident, at least for the first 25 cases, somebody will be sitting in the side scope and then teaching them, how deep you are, how long the tunnel is, how short it should be, and things like that. So that is called one-on-one training. But that is when you are getting that consciousness, but you're still incompetent. So this is a very important stage. When somebody needs to go from this stage to the next stage, which is the conscious competence, sometimes we leave them to do alone, and then they face a lot of problems, or you criticize them after they have a complication, or when you review that case, if you have a recording. So what we have done consciously is the next 25 case. So this, again, thanks to COVID, we learned during COVID, where there is a saying that never let a good crisis go waste. So we didn't want the COVID time to be wasted. So we experimented a lot of things. And one is this called the GoPro, which is a live surgery which you can see from a GoPro. So we gave a name for it. It's called GoPro Operations Live on Facebook. So it's a very simple thing. Your GoPro goes to an adapter like this. So this is a Chinese made adapter which goes into your beam splitter, and it can be fixed in just couple of minutes. So before somebody operates, if they want to be prepared, and then you go live on the GoPro app, which is called the Quick app on your iPad or in your iPhone, and then you can go live, and then somebody can see your surgery live. So that's the best part. If somebody can see you in the second 25 or 50 patients, and then tell you your axis is small, you need a bigger axis, or your axis is running away, can you pull it back? Your cortex this is not a good idea, your pupil is small, can you get it bigger by putting adrenaline or phenocaine? So things like this, the GoPro makes a big difference for us. So this we call as live mentoring. Like what you see, this is our Facebook page. When somebody is operating, so this is a recording which you see there. The best part is all these cases are archived in that page. So somebody can, the person who has done it can also retrieve that recording and have their own saving of it. But all these help. So it's a kind of a closed channel. Only on invitation people can subscribe and come in, and once they leave they are also removed from it. And what you see is all live done. So live mentoring happens. See there, if you can see, it says stop and call for help. That means they have gone beyond the limit where if they continue, they'll have a complication. So what we have seen is by doing this, they're unconscious. They become more conscious of what they are doing. The pupil is small, let me put adrenaline. This cortex is sticky, let me do a second hydro to get that cortex off. That really helps them to think at the right time than criticizing them after having a problem. So what we do actually is we have systematized this, the second half of it, the second 25 cases. We have somebody like a senior consultant or a senior resident. So if you see her, she is on their EMR looking at patients, and also there is a screen where the live surgery is playing. So only 1 or 2 people will be seeing that, so that we don't want to intimidate the surgeon who is operating also. So they will be seeing, and then whenever they need some kind of an advice, then they would put that advice in the comment. Now where you can't talk directly, but you'll put it on the comment, and the comment will be shown to them on the iPad there in the operating room, like how you see the comment here. So you can continue to put the comment till they operate, but if they are doing a good job, you can just watch and then just leave on them to operate. So what best this can do is, this can help you to do kind of offline and online. So this is another channel which every resident will have. So there are several residents here. If you are interested, they'll be happy to show you. So they are advised to upload in their own YouTube channel somewhere close to 250 small incision and 50 phacos and any other surgeries they do. So the best part is, you can, whenever you have a doubt, you put it on a timestamp like this. And then I can go exactly at that timestamp and then give my opinion there or my feedback there. This is offline mentoring. So it helps not only online but also for offline. So once you have it in the YouTube, you can use all the facilities which the YouTube gives you to do. Unlimited access, unlimited number of things. You just have to put it into that, compress and put it into that. It's going to stay there with you. And you don't have to share that with anybody. You can share with your mentor or somebody who you want to really discuss that case. It may be national, it may be international. So even this we did when we started learning the GATT. My colleague Swati, when she was learning GATT, we were sending this to Davinder Grover on our YouTube. And then he would put his comments. Swati, this suture, your cautery is too much. Your cautery is too less. You have to make the right cautery. Keep your low temperature cautery little away. So some of these tips are very, very important. If you don't understand the tips, especially the side port, where it should be to insert your cannula. So this helps beyond just online, also for offline mentoring. And what we do actually is they sit with the mentor like this. Can we have the audio? So the mentor can discuss with them. So here, I'm just sitting and discussing with one of my residents. I'm saying, see, you're pulling that cortex, and I can see the capsular folds. So that's not going to help you. You have to just do a saline jetting, release that cortex and then aspirate. So things like that, it will really help you when you are doing a little bit of, leave it, it's okay. When you are doing those offline mentoring. And more importantly, we used to call these meetings as complication meetings, but in the recent past we have been calling this as performing successful cataract surgery, reviewing them every week, not to criticize but to say, how we can do this better. And this has helped us to significantly take them to the next stage, which is the conscious competent stage, which is very, very important. And once they go to that stage, I think then the other stages are very easy, to become unconsciously competent, where you're thinking of something else, you're thinking about conference and you're still operating, or you're thinking about what is there for the lunch and then you're still operating. That happens. We do that now, but still if you're conscious, you can do a better job. So we have seen a significant reduction in the complication rates, at least in the last few years. I'm sure you would have seen our chairman giving a talk on the complications. Now we are closely monitoring, at least in Pondicherry after these interventions, especially the resident complication or the trainee complications have significantly reduced over the period, like how you see here. It's been from 4.62 to 3.13 to 2.47. No, that is where you're really learning the surgery. Your first 100 to 200 is one where you're really learning the surgery. And once that complication comes down, the confidence level goes up, and that helps them to go quickly to the next level. So I think this is where the mentors really come, where you can really help them, pull them back, and make them from conscious incompetence to conscious competent stage. So these are some of the practices at least we are doing. I think I'll just quickly show you. So this is the YouTube channel, which you see. Can you get the screen? So if you have any questions on that part, I'll be happy. But we have a few of the residents, who are right here. Now, if you are interested, they can show you exactly how that Facebook Live works, or even the YouTube channel where they upload. Because what we have seen is this is what the next generation need. They are into more of social media, and they really kind of exercise all this in their day-to-day activity. So once you show them how it's being done, then they quickly elevate it to the next level. For example, we were saying them to save it on a hard drive or in their cloud, but somebody came and said, I can do it on a YouTube, which is much more simpler than what you are saying. So these are things which, once you start talking to them, they can with their ideas and with their expertise, they can elevate it to the next level. So if you're interested, you can show. Can you raise your hands, people who can show them? So if you have any questions, I'll be happy to take, because the other speakers have all left. But anything related to this or with the innovation, I'll be happy to take. Yeah. Exactly. So there are a lot of simple innovations. Like whatever I'm showing you, they are also not very expensive. See, when it boils down to recording, right? So there are expensive recorders. Sony comes up with different prices, which goes into your beam splitter, and then you need a scope to attach that and all that. But there are mobile-based adapters, where you can just put it to your side scope. If you have a side scope, they put the mobile and record. The GoPro, which I was showing you, is the most less expensive I have seen, at least in my life, which makes brilliant videos. It may just cost you 1.5 lakhs. The GoPro, the adapter, and also an iPad to that. But the most important thing is that's not the regular GoPro. It's a modified GoPro. So that was modified by a company called Backbone in US. So a lot of people just buy a regular GoPro and then they call me. I said, it's not the regular GoPro. You have to get it from that Backbone. So what they do is they remove the front part of it and they put another lens so that it can be used for any microscope, even a lab microscope, because the video quality is so good, so that you can use it in any microscopes.
Display.
Any other questions? I can go and see. I was seeing live when the glaucoma session was going on. Now I was waiting for my talk and I was seeing live this particular surgery, which was done some 58 minutes back. So like this, you can have all these things archived, in that particular page. So if you go to that page, you have everything here. You have everything here. So anytime you can go play that particular case and see what happened. If somebody wants to do a kind of an offline work. So this is how you can see somewhere if somebody needs a help, you can put a few comments so that they can quickly react to this. Like just centering the eye is sometimes important. You just center the eye, and then these are some people who have already kind of going to the next stage. So whenever they need, like don't use adrenaline when your pupil is fully dilated. Then it doesn't dilate when you really need it. These are stuff which sometimes you have to put that in the right time. And this is the channel, like how it really helps the residents to kind of archive all this, like what you see here. So they can put a timestamp and ask their mentor. Harni, you want to show quickly how it works?
For example, in this case, so this case I shared with my senior, and he has seen my video and commented with the timestamp. So when I click this timestamp, it will go to that point exactly, and I can compare the comment with that point of the video. And also here I'll put which case and the grade of cataract and which eye was done, and what I felt during intra-op. All the comments I'll enter here, and I'll just compare it with my seniors' comments. Like here also, when I click the timestamp, it just goes to that time of the video, and I can just compare, learn from the comment of my senior.
So that's what they can do. They can give you better ideas, and then they can elevate this to another level, which also helps you. Once you have all this, you have a lot of good collection to train your future residents also. I have tons of buttonholes, premature entries, or somebody trenching right into the capsule. So you'll have these collections also, because this is what we need to do. We can't wait them to make those mistakes. Before they make the mistakes, can we bring that consciousness? And that is possible with the technology, and that is possible with the new generation. And that's the message which we wanted to give you in this course also. Thank you again for attending patiently this course, and I appreciate that.